Good morning, folks. Today we are discussing the second post-test CKD quiz. So let's get started. The first question was uh, diabetes is the most common cause of CKD. It is indeed, and most of you got it right. The second question focused at duration of CKD. The definition of CKD is GFR less than 60 for 3 months and not 6 months, and most of you got it right as well. The third question was a distractor. CKD group 3B has GFR 30 to 40, has GFR 30 to 45, right? So, and while 3A has 45 to 60. So this question, most of you got it wrong, but it was a distractor. Remember, CKD 3 less than 60 GFR for 3 months, and it is divided into 3A and 3B, while CKD 4 less than 30 to 15 and less than 15 ESRD or CKD 5. Cockcroft-Gault is not the best formula for estimating GFR. We have the MDRD equation. There, they bring in the albumin part as well. So most of you got it wrong, maybe because I emphasized on it. Then the other question, ACE inhibitors should be used in ESRD for BP control. Now they should be used in CKD. Most of you got it wrong actually. ACE inhibitors should be used in CKD, but beyond a creatinine of 3.5 or 4, you will have a high risk of hyperkalemia, right? As I told you, you must know, you must remember the drugs for hyperkalemia. So the answer, if the question would have been ACE inhibitor should be used in CKD, so that would have been right, but this answer is wrong because it is ESRD. The patient already has a high grade renal failure and CKD, and so it will cause hyperkalemia. The antihypertensives preferred in CKD are calcium channel blockers and ACE inhibitors, but the CKD should not be of high stage, right? Hemoglobin goal for anemia in CKD is 10. That is exactly right. We do it by erythropoietin stimulant agents, and importantly, the goal is we use, but if we use erythropoietin agents, we have a risk of MI and stroke as well. So the optimal target is 10 due to this benefit risk trade-off. The PTH goal in ASRD is less than 300. Most of you got this uh, wrong. It is indeed 300. Okay. Sevelamer is first line phosphate binder in CKD. This most of you got this wrong. It is not the first line phosphate binder in CKD. The first line phosphate binder are calcium acetate or calcium carbonate. Only when your calcium is high and phosphate is high as well, then sevelamer is first line phosphate binder. Calcified access, as I already did, calcified access is calcification of skin and necrosis of and vasculature. So it will be diagnosed by skin biopsy rather than renal biopsy. Most of you got this right. And question number 10, metalozone is a loop diuretic and a sigmoid. This is wrong because metalozone is a thiazide diuretic. And only loop diuretics have sigmoid response curves. Half of you got this right. Spironolactone is a diuretic of choice in cirrhosis. That is right. Most of you got it right as well. Because spironolactone counters secondary hyperaldosteronism in cirrhosis due to decreased extracellular effective blood volume. Hypouricemia is a common complication of loop diuretic. This question is wrong. This question, most of you have marked true, which is wrong. The hyperuricemia is a common complication of loop diuretic. AV fistula is commoner than internal jugular access for hemodialysis. It was a trick question. Though AV fistula access is the best method for internal jugular access for hemodialysis, but it is not the most common method for hemodialysis because the number of plastic surgeons is less. So it is best, but it is not the most common. Generally, we put in the internal jugular catheters for dialysis as a temporary measure. Normal hemodialysis is used almost normal frequency is 3 days a week, not 5 days. So most of you got it right. CRRT preferred for hypotensive patients. Most of you got it right. So that is right. Disequilibrium syndrome is due to cerebral edema. Yes, what happens commonly in dialysis due to shift of fluids across the semi-permeable membrane, you can have electrolyte disbalance. So cerebral edema is the cause of cerebral edema, and that is seen in CKD. Peritoneal dialysis can be self-administered. Most of you got it right, and it is indeed self-administered at home, though there are some risk of abdominal infections as well. Isothenuria and restless leg syndromes are common feature of CR. It is right. Isothenuria is fixed specific gravity, and restless leg syndrome are due to nutritional deficiencies. These are common features. In renal insufficiency, GFR is less than 20% normal, and signs of azotemia occur 19. This was a trick question. As I told you, there are many stages of CKD. So insufficiency, you only have mild urea and creatinine derangement, while in failure or ESRD, you will have GFR less than 20%, that is in chronic kidney disease. So renal insufficiency is not CKD, right? So this answer is wrong. Renal insufficiency occurs very early. It is only when there is failure or ESRD the GFR is less. Both renal osteodystrophy and osteomalacia have hyperphosphatemia. This answer is wrong. It was a trick question. Most of you got this wrong. Renal osteodystrophy and osteomalacia, while renal osteodystrophy indeed does have secondary hyperparathyroidism due to hyperphosphatemia, osteomalacia, your phosphate is low because it is due to vitamin D deficiency. Nail and half nail syndrome is a pigmentation in nail, right? It is commonly seen in CKD and not in ARF. Peripheral neuropathy is common in ESRD and doesn't improve after dialysis. That is true. There are some irreversible complications of dialysis. Phosphate binders are initial treatment of choice for phosphatemia and CKD. Yes, this is true. Phosphate binders are of many types. As I told you, calcium acetate and calcium carbonate, which are used when calcium is low and phosphate is high, while which is used where calcium is high and phosphate is high. Cardiovascular death is most common cause of death in ARF and CRF. While cardiovascular death is indeed the most common cause in CRF, it is not the most common cause in ARF. Okay, acute renal failure. CMV is the most common kidney infection, and EBV, induced lymphoproliferative cancer, most common neoplasm after kidney transplant. This is right. That is why we test for CMV infection before a kidney transplant. Beta blocker can be used as adjunct for treatment of hyperkalemia. This is wrong. We use beta agonist, right? And beta agonist will nebulize with beta agonist, which will shift the potassium back into the cell.